Hey everyone. We are very excited to have you all with us for CurePSP's quarterly Ask the Expert webinar. I'm Jessica Shore. I am the Director of Clinical Affairs and Advocacy here at CurePSP, and it is a privilege to be moderating this program with you. We had over 375 people register for this webinar today, which is amazing, and I'm so glad that you're all with us. Today, our expert is Dr. Travis Turner, who I'll introduce in a moment, but he'll be discussing the very important topic of assessing cognitive changes with progressive supranuclear palsy, corticobasal degeneration, and multiple system atrophy. A few housekeeping items before we get started. This program will be about an hour long, which will include both Dr. Turner's presentation and our live question and answer session. Dr. Turner has agreed to share a copy of his slides with all of the registrants. His slides and the link to the recording of this webinar will be provided in a follow-up email to those who registered. So please be on the lookout for further communication. The webinar will also be archived on Facebook and on our YouTube channel for anyone to view at any point later on. Dr. Turner will likely address many of your questions throughout his presentation, and realistically, we won't be able to get to everyone's questions today, but if you would like to share a question with us, you're welcome to type it in the comment section of the platform that you're using to view this. We also have the questions that many of you submitted when you registered for the program. You can also use the comment box to say hi and where you're tuning in from if you'd like. I also do want to note that this webinar and Dr. Turner's presentation and the responses to the questions later are not meant to be medical advice. So with that in mind, we recommend not sharing any personal health information in the comments. And we also encourage you to talk to your healthcare team if you have your own specific medical concerns and questions. All right, so at this time, I would like to introduce our speaker for today's Ask the Expert webinar.
Hey.
Hey, Dr. Turner.
Great to see you.
I know he'll share a little bit more about himself, but Dr. Travis Turner is a neuropsychologist at the Medical University of South Carolina, which is one of CurePSP's 30 centers of care. He has been active in efforts with the movement disorders program at MUSC for over 15 years. His clinical activities include neuropsychological evaluations and interventions for patients with Parkinsonian diagnoses, and his research is aimed at developing new ways to measure and treat neuropsychiatric symptoms and movement disorders. I have known Dr. Turner for several years now from my life before CurePSP, actually, where we had collaborated on different programs and presentations related to mental health for Parkinson's disease. Mood and cognitive changes are among the most common topics that our community members with PSP, CBD, and MSA come to us wanting information on. So I thought it would be really helpful to have an expert join us to speak to that. Dr. Turner, welcome. It's always a pleasure to get to see you and work with you. Thanks for being with us, and please take it away.
Great. Thank you, Jessica. Always a pleasure to work with you. I am a neuropsychologist working in a movement disorder specialty clinic here. A lot of what I do are assessments of patients with various movement disorders, including Parkinson's, PSP, corticobasal degeneration, and multiple systems atrophy. And what I was going to talk with you about today, if you want to go to the next slide, are nothing that needs a financial disclosure. Next. Was going to talk about some of the basics of atypical Parkinsonisms. And a lot of you have seen this before, maybe some of you haven't. And I think it's a good starting point to just talk about how the atypical Parkinson's are related to Parkinson's disease. Just a little bit on the general cognitive profiles that are associated with these atypical Parkinsonisms. And then really kind of focus on the evaluation process, what it's like when you come to see someone like myself. Why you might go through the process, when you would, and how it works. And then importantly afterwards, talk a little bit about what we do with this, with a diagnosis if one is made of a cognitive disorder associated with an atypical Parkinsonism. All right. So real quickly, you can go back and reference this later if need be. This is the alphabet soup of the different abbreviations that we like to use. I'll probably say them throughout this talk, but in case I do throw out one of these acronyms, and it's not, you're not sure what I'm talking about, you can always go back, look at these slides later and find out. So let's talk about what the atypical Parkinsonian syndromes have in common with more typical Parkinson's disease, or the kind of the garden variety Parkinson's disease. They all involve lower levels of dopamine in the brain, in the circuit called the basal ganglia that's important for regulating movement. So they all also involve problems with movement. These are all progressive conditions. Unfortunately, cognitive and psychiatric symptoms are common across Parkinson's disease and the atypical Parkinsonisms. And they all involve changes in the middle part of the brain, or the, as we like to use a fancy term for it, the midbrain. All right, next slide. Now, unlike Parkinson's disease, which is actually fairly common, perhaps 1 to 2% of adults over 65 carry a diagnosis of Parkinson's disease. These atypical Parkinsonisms are really pretty rare, more like 1 in 10,000 or perhaps even less. And for corticobasal degeneration, maybe 1 in 100,000. So if you have these conditions, it's very unfortunate. However, you can consider yourself to be very unique. You found something unique to have. The motor symptoms tend to be less responsive to the medications for increasing dopamine in the brain that we would use in Parkinson's disease. We also find that rest tremor isn't a real common symptom. Visual hallucinations are pretty common in Parkinson's disease, uncommon in MSA, and very rare in PSP and corticobasal degeneration. Unfortunately, the progression tends to be faster, not just for cognitive symptoms, but the other motor symptoms in general, and the atypical Parkinsonisms versus Parkinson's disease. Now, both MSA and Parkinson's disease involve the accumulation of a brain protein called alpha-synuclein. It ends up clustering and kind of getting sticky, and is thought to interfere with brain function. PSP and CBD are a little bit different in that they primarily involve elevated levels of a protein called tau, which is actually also involved in Alzheimer's disease, but plays a very different role. When we look at brain structure with regular Parkinson's disease, nothing will look different. It looks pretty much normal, whereas we can see some changes in these atypical Parkinsonisms. All right, next. Some other things that separate them. With MSA, the main thing that we're oftentimes dealing with, especially early on, are problems with bladder and bowel continence, as well as orthostatic hypotension, which is lightheadedness when standing. These are frequent early problems, whereas if they come up in Parkinson's, it's usually not until quite a bit later. In progressive supranuclear palsy, or PSP, we find that the eye movements are a little slower and less exact. There's oftentimes early problems with falls due to balance and postural instability. These can come up in Parkinson's disease, but usually not until a bit later. In corticobasal degeneration, the main thing that we'll see are problems with sensory motor function and doing skilled movements that tend to be much worse on one side than the other. For both PSP and CBD, problems with cognition, especially executive functions, which I'll talk about a little bit later, and changes in social graces and other social behavior can come up early, whereas this would be something a little bit later on if it comes up in Parkinson's. All right, next. So let's talk about some of these cognitive profiles of atypical Parkinsonism. I list out here some of the main domains or aspects of cognition that we tend to focus on in these evaluations. And the things that really stand out in PSP are problems with reduced verbal fluency, being able to speak quickly and name different things. Like, for example, animals. We'll ask people to name animals or different types of fruits and vegetables. It's not that that information is gone. It's just being able to pull it down is harder, and sometimes being able to form and express the words is impaired. And then we also see problems with executive functions. And so listed below that, I have some different parts of executive functions or aspects of them that we see as being impaired, like multitasking, doing two things at once, or being impulsive, making decisions without good, careful planning, as well as trouble with judgment, problem solving, things like that. In corticobasal or degeneration, verbal fluency is often reduced as well, so that's not unique to progressive supranuclear palsy, but we also see a lot of stuff with visual spatial planning, doing skilled movements and skilled tasks, especially with them on the more affected side, and problems with spatial relationships. So, for instance, judging where one is in relationship to their environment, bumping into things, trouble with dressing, knowing where the body is in space. Next slide. The cognitive profile in multiple systems atrophy, or MSA, is really pretty similar to what we see in Parkinson's disease, where the main thing that is impacted primarily is processing speed. So people will maybe have a little more difficulty following fast-moving conversations, as well as organizing their thoughts and expressing them to participate in them. All right. So what you noticed maybe as we went through those is that memory wasn't bolded. Problems with memory can come up, but it's usually not the main thing. And it usually doesn't involve rapid forgetting. With Alzheimer's dementia, or AD, that is the main thing that we see. That's the presenting thing. It's usually the first thing, problems with rapidly forgetting new information. With DLB, or dementia with Lewy bodies, this involves some degree of cognitive changes as well as some Parkinsonism. But the cognitive changes and problems with things like anxiety and visual hallucinations are present early and much larger than the movement symptoms that we would see in Parkinson's disease. In behavioral variant frontotemporal dementia, or BVFTD, the main thing that we'll see here are problems with social graces, behavioral changes, and there may not be any big problems with movement. In primary progressive aphasia, we'll see language being very impacted and really minimal problems, if any, with movement and walking. And then of course, with stroke and head injury, rather than something that, develops gradually over time, these are acute onset after usually a known injury or known stroke. And then over time, we'll see improvement or stability rather than progression. All right. So when people come to see me, a lot of times the question is this normal aging? Is this an atypical Parkinsonism, or maybe something else? And so here are the things that I'll tend to hear about the most. Problems with short-term memory, which can mean a lot of things to different people. Usually it's forgetting details of conversations or routine events. Sometimes problems with word finding, like, oh, what's the name of that actor? That'll be considered a problem with memory. It's a little bit more related to word finding, but that's okay. Also problems with aphasia, or inability to communicate. Sometimes worse for being able to speak versus writing, as long as the dominant hand isn't too affected by the movement symptoms. Sometimes a feeling of being locked in because a person knows what they want to say, but they're just either not able to say it quickly enough to be heard, or they just can't form those words. Um, and then some other things, like losing your train of thought, walking into a room and forgetting why, the kind of stuff that we all do from day to day. I certainly do, but just happening with increased frequency. All right, next. When I talk to the care partner or the other person's report who knows the patient well, these are some of the things that I'll hear about. One of the biggest things is someone just doing things a lot slower, and not just because they're moving slower. It seems to be that they're thinking slower, and it's harder to kind of put the pieces together to come up with a game plan for what to do. And generally, I'll hear about people being less reliable and following the daily routine. So maybe some days they can do something. If they go outside, they'll remember to take out the trash, they'll remember to shut the door, but maybe other times not. That kind of thing. Again, the mistakes we can all make, but just more frequently and to the point where it might be interfering. Um, with progressive supranuclear palsy, I'll tend to hear more about poor decision making and impulsivity. Um, Again, these are all kinds of things that we think about as being executive dysfunction, or in the past we called them frontal lobe dysfunction because it involves the front part of the brain to carry these tasks out. All right. And here are some other terms that come up and some symptoms that come up. Anosognosia is a big one. So this is the unawareness of deficits. It's a phenomenon that is really common across all of these different conditions. For instance, someone with memory problems will tend to forget that they forget, so they're really not so aware. The person who has problems with judgment may not be very aware that their judgment is poor, or they may recognize it after the fact, but not carry that lesson through to the next time the situation comes up and then kind of repeat the mistake. And another thing that I'll just kind of touch on here is trouble with dual tasking. So this would be kind of like walking and talking. The issue here is that it's harder to walk without stumbling with most of these conditions. And so a lot of the mental bandwidth is focused on just making the feet move right, not freezing, not stumbling. And so therefore it's harder to carry on a conversation while walking because some of these movements and other things that were once automatic now require conscious effort to be able to do effectively. Whenever we're asking or hearing about these struggles, we always ask about, well, what impact is it having on day-to-day life or activities of daily living? And so we'll always ask about driving, for obvious reasons, safety, looking at bills and financial planning. Is there good oversight? Are bills being missed or double paid? Are people making risky investments? Or having trouble with mental arithmetic that might be causing problems in various ways. Struggles with home technology, that's a big one. Cooking, which involves a lot of executive functions. You have to multitask and plan and try to coordinate the timing of different things. And then, of course, person's ability to communicate and interact socially. All right, next. So already I've kind of briefly touched on the cognitive symptoms, the motor symptoms that come up in these, the autonomic symptoms, which would be like the bladder and bowel and regulating blood pressure and MSA, as well as mood and anxiety. So when we talk about these things in Parkinson's disease, as well as atypical Parkinsonisms, we tend to talk about them like they're separate things that happen at different times. Next slide. But here's the reality of it. Unfortunately, is for the person who has this, what they're experiencing is right there in the middle. It's all of these things together at the same time, and they all kind of lay on top of each other and can be really confounding. So for instance, if you go back one real quick, if someone has a lot of problems with being lightheaded, like in multiple systems atrophy, they'll oftentimes have a fear of falling. This is then when they're walking, this is going to impact their walking because they maybe are a little overly cautious and taking kind of shorter steps, and this then has an impact on cognition if they are, asked a question while they're really trying to focus on just walking. A lot of these things can lay up in different ways, and it's important to recognize, I think, that for someone who has one of these conditions, this is really where they're at. It's not just a cognitive, motor, mood situation. It's really all of them kind of together. Next slide. And this is what leads to oftentimes doing the evaluation to see if there is a cognitive disorder in place. The first step is usually just kind of a screening examination. And so this can be done by a primary care doctor or a neurologist. In my opinion, if there is a concern about cognitive changes, it's good to have a separate visit just for that purpose, rather than trying to tie it into a visit where other symptoms might be discussed. It's good to have a dedicated visit so that the doctor will be able to dedicate the time to actually understanding what the concerns are, and then ideally doing some abbreviated testing, usually about 5 to 10 minutes. Many of you are probably familiar with this. You have to, spell a certain word backwards or count backwards by a certain number, remember 3 things, provide the day of the week, the date, and so forth. And so this is good as a general screening, just to kind of see where someone's at and see if further workup might be needed. But it's usually not enough to kind of disentangle some of the complexities of what may be going on. So that leads to the formal neuropsych assessment, which is what I do. And so this is usually done when there's questions after a screening process. If there's uncertainty about the differential diagnosis, like atypical Parkinsonism versus DLB, dementia with Lewy bodies, or Parkinson's disease. And when there are treatment considerations, trying to figure out which symptoms maybe are the most interfering. We also consider this early on if someone is continuing to work with one of these atypical Parkinsonisms, and we want to make sure that they're not in a position where they're doing something where a small mistake could prove really expensive, costly, or hazardous. If somebody's living alone, we want to take extra special care and pay close attention to anything that might impact their ability to continue doing so, or if they're taking care of someone else, which happens quite often as well. Sometimes if there's a real strong family history of dementia, or if we're trying to determine how much of an impact anxiety may be playing here. All right. So these assessments are performed by someone like me. So I'm a licensed clinical psychologist. I do very, very little therapy. I'm mostly doing evaluations, and that's true for most neuropsychologists. We go through a similar clinical psychology program, but then after our internship, which is usually focused on doing cognitive diagnoses, we'll also do a second 2-year fellowship. For me, mine was focused in movement disorders, because I knew actually very early on that this was the thing that was most interesting for me and my passion. And when we do these evaluations, it usually is about 3 to 4 hours in total, which sounds really daunting, but involves a lot of different steps. And I like to think that we get people through it. And while it is going to be taxing, it's not just pure drudgery. You're interacting with someone the whole time. So I'm just going to tell you a bit about what the interview portion, the testing, and the feedback look like. So if you're going to have one of these evaluations, you'll know kind of what to expect from the visit. All right, next. So the interview portion, this is not a psychoanalysis session by any means. It's really very focused on whatever the presenting concerns are, cognitive, psychiatric, whatever they are. We're asking questions so we can understand, what's going on. What are the strengths and weaknesses? What kinds of things are giving a person trouble? What are they doing in a typical day? It's great to have a spouse, child, or some other knowledgeable informant there to provide some additional perspective. We'll also, of course, touch on some medical history that we can't find in the electronic record or the referral notes. and then just get a little quick bio so we've got a context to put all this into. All right, next. Now, the cognitive testing. So this is what everyone gets anxious about. And I think part of my job is to be a bit of a cheerleader to get people through it and to make a few jokes along the way so people don't get too worried about how well they think they're doing or not doing. Everyone wants to know, well, hey, wait, I'm 75 years old. Is this, or do you take age into consideration? And yes, we do. The tests that are administered are not just ones that we cook up in our own head. They're developed and standardized so we know what normal is for a person's background, which always includes age, sometimes other things like gender and education as well. And it's important to know that the tests are hard for everybody. Nobody gets them all right. Certainly, I wouldn't even come close. And there's strengths and weaknesses of this approach. The nice thing is that we're able to get better measurements, and we're able to assess if, let's say, if someone goes from being at the 99th percentile, really, really good at something, down to the 50th percentile, the test can capture that change. Whereas if we just threw softballs, someone at 99th percentile would get them all right. And then if they went to 50th, they'd still get them all right because the tests were too easy. But it is good to know that they are hard. The feedback session, I always do this immediately after testing. Sometimes in different centers, it might be a little bit later, especially if trainees are involved. Always great to have someone else present to hear what's being said and to make sure that all that's being taken in, because it can be a lot to get this feedback and process depending on how complex the information is. And we'll always talk about whatever the recommendations we're making, either directly to the patient or to the referring provider, which can include things like medications to use or not use, whether certain types of therapy could be helpful, if we feel like additional studies are needed, like brain imaging or sleep study, and then other stuff as indicated, kind of based on a person's situation. All right, next. So assuming you've gone through this process and a diagnosis has been made, what do we do with it? So let's kind of go through some different outcomes. So if we say normal cognition, this of course is the best news that we can give, and it does happen. Really, it is true that I give this feedback. Not everyone with an atypical Parkinsonism will get a cognitive diagnosis. And what do we do with this? Well, the good thing is that if you've had concerns before and the result is that we say, hey, cognition looks normal, you don't have to keep second guessing yourself and then cataloging and making, a whole lot out of all these little slips. So that's good. It can help people be just kind of more present and just engage with life rather than constantly analyzing themselves. And we don't make unnecessary limitations on independence. So if we see that cognition is normal, well, then we don't have to say, oh, well, this person maybe shouldn't be, managing their bills, or they shouldn't continue to work. I mean, there could be other reasons why it wouldn't be good to say manage bills, work, or drive, but we can at least say that it's not due to, there isn't a cognitive basis for that. And this also opens up options for different types of medications and other interventions. And we establish, this is also really important, we establish a baseline for comparison if needed in the future. So if a few years down the road, someone does find that they're struggling more in day-to-day life, or if there are other changes, we now have a reference point so we can repeat that testing and then see what, if anything, has changed. All right. The next outcome, which is really very common, this is probably the most common diagnosis that I make in cases of atypical Parkinsonisms, and this is mild cognitive impairment. So what mild cognitive impairment is in a nutshell is that someone is having some struggles in day-to-day life, but is largely independent, meaning they can be left alone at home and kind of get through the basic tasks of day-to-day life without assistance. But there are some struggles. And then when we do the testing, we see some mild weaknesses, some areas of deficit. The biggest things here are the evaluation process will inform what the weaknesses are so that you can avoid potentially adverse consequences. Like if we find impulsivity, then we know to set up some safeguards to prevent someone perhaps from um, spending a lot of money or having access to things that would be unsafe. Could be guns, um, could be certain types of power tools. Has been one that comes up not too infrequently. But we also identify the strengths so we don't put unnecessary limitations on. So if someone is not showing deficits in a certain area, then we don't just make kind of a blanket decision to put up guardrails over all the fun stuff in life. And again, we have a baseline for comparison. All right, next. This is, of course, my least favorite diagnosis to provide, but when it's present, it's important to know about it. With a dementia diagnosis, we at least now have a name for the struggles, which can be really important actually for the care partner who's been observing this and, trying to manage it, and perhaps not wanting to acknowledge it. It's a very understandable thing that you don't want to see your spouse or your parent in this light. But now that you know it, you can perhaps start that grief process, moving from fear of this happening towards acceptance, and then being able to actually address it directly. In many cases, we can also identify the cause of the dementia, which is really important for treatment and planning and sort of knowing what's ahead. And really, the focus here is becomes on quality of life, not just for the person with the condition, but also for their care partner. And so a lot of the creative problem solving goes into supporting good quality of life. All right, next. So putting it all together, changes in thinking are pretty common in the atypical parkinsonisms. The mild struggles can be present really early on. And it can sometimes be difficult to discern, is it a cognitive thing or is it some other facet of the disease that's causing the issues? And when these questions are there, the evaluations can help with the diagnosis, starting with screening, and then moving to the full evaluation if that's what makes the most sense. And really, regardless of what the outcome is or what the cognitive diagnosis is, these results hopefully will inform the treatment options, as well as balancing, safety concerns with independence for highest quality of life. That's really the key. We want to keep people safe while also supporting quality of life and planning for the future. So I know that's a really quick run through everything, but I really wanted to save time to be able to answer some specific questions. So thank you very much for the time, and I guess we'll move into the question portion.
Thanks, Dr. Turner. That was not only comprehensive, but you moved through it at an impressive pace. And so I appreciate you really seeing the importance of having the Q&A portion of this. So first of all, we have people from attending from all over, which is really neat. Ecuador and England and all over the US and Canada. So we've gotten a handful of questions in the chat, but I am going to start with some questions that we had received during registration. And one, I know you talked a little bit about the communication challenges that can come up with these diagnoses, and this speaks to that. So this person said, my sister can no longer speak. It's hard to know if she understands when I talk to her. Is there a way to assess someone's cognition once they're no longer able to communicate?
Yeah, it's a great question. It's one, unfortunately, that we see a lot of in people who have PSP, and there are ways of doing that. So what we will tend to do is we will tend to have a set of responses on either a piece of paper, sometimes a poster board, sometimes a dry erase board, where a person can point to a response so they can indicate without having to speak. There are some folks who are unable to speak but are able to write, and so we'll work with it that way. There definitely are ways of being able to assess cognition for people who are um, unable to speak. It is more challenging, um, but it certainly is possible. And there's a lot of things that a lot of types of tests we can do that will tell us something about how different parts of the brains are working that don't involve any fine motor movements. They involve more kinds of pointing and other gestures. So I wouldn't let that be a barrier to trying to get a diagnosis.
Okay. Okay, thank you. And, as you're sharing that, so along those lines, I'm thinking, can you speak maybe you sort of talked about how you work with neurologists in a way, to help with the diagnosis, especially or if cognitive challenges are coming up in neurology visits and then they refer to you. But as far as communication goes, how does your what you do overlap with, or how do you work with speech language pathologists in the care of these diseases as well?
Oh, we work very, very closely. So where I tend to see most of my patients with the atypical parkinsonisms are actually in the context of our interdisciplinary clinic, which I just came from this morning, where we have a speech and language pathologist, we have an occupational therapist, and so a lot. If someone comes to me first without having seen speech therapy, my evaluation will help the speech therapist understand what cognitive limitations may be there that would impact the types of speech therapy that they would go and do. So, for instance, if memory is impacted, then they'll be sure to do more work on rehearsing things and repetition and providing instructions and interventions. Or if sequencing is hard or is deficient, they'll do more things to sort of support that. And yeah, the evaluations that the speech therapists do are really key. Both of those pieces of information come together for the treating neurologist.
So are you also, I know, I've known many neuropsychologists over my 10-year career here, and some focus more on evaluation and some do some treatment as well. And there is that overlap, especially with speech therapists there in terms of like what exercises or daily modifications, sometimes even overlap with occupational therapists. Can you talk a little bit more about, what that can look like maybe in your practice or your experience with others? Like, what am I trying to ask? Sometimes we're all for the interdisciplinary team model. I also know sometimes people can get a little confused or overwhelmed with, who to see for what and for assessment and for treatment and management. And so if you could just clarify that a little bit too, that'd be great.
Sure. So occupational therapists are oftentimes my heroes because I feel like I do these tests and do these evaluations to make a diagnosis. And the tests that I do in clinic are supposed to relate to and inform what a person is doing in the real world in everyday life. And so the occupational therapists are great because they are then going and meeting the person in the real world and helping them through, like identifying specifically, if it's a problem with dressing, is it because of decreased sensitivity in the fingers, making it hard to find a button and do a button? Is it because of a visual spatial issue? So they can oftentimes diagnose some of these specific struggles in real world settings and then come up with a plan for, okay, how do we work around this? Okay, it's hard to bathe. How do we get someone in and out of the shower safely? And they also oftentimes will go into the homes, which is also really great. And then build skills to support safe mobility. They work very closely, of course, with the physical therapists who also um, focus on building strength and building good muscle memory to do to say move to walk without getting injured and thinking about
Mhm.
assistive devices. I'm not sure if that really got to your question. I personally don't do
Yeah.
a lot of
Yeah.
cognitive therapy. Sometimes some of our speech and language therapists will do that. The only types of therapy that I will tend to do are with really challenging patients where their behavioral issues can't really be addressed in with a community provider, and so then I'll find a way to kind of see them somewhere. Usually it's during a research day, but um, that's kind of where I'll come in with that.
Yeah, that makes a lot of sense. So what I'm hearing is your role or a neuropsychologist role in that kind of setting can be, I mean, in many places, of course, but a large one is if other team members feel like there's these cognitive challenges that are coming up, they might be intersecting with other symptoms and they really need someone to delve into that deeper. And then that, what you learn from them in your testing kind of helps to inform their very practical management techniques and skill building and exercise, home exercise programs, as well as diagnosis.
Yeah, it's that interaction slide that I had, just trying to see how those different pieces are coming together.
Okay. Um, sort something else too, as far I know this is sort of a hard one to get into. It's so complicated, but can you talk a little bit more about apathy? So specifically when someone registered, they had shared the question. They said, my partner used to love listening to music, and this has decreased almost completely. So can you talk more about apathy and maybe what recommendations you have for how to deal with that?
Yeah, yeah, apathy is really challenging. Apathy is a problem that almost no patient comes in with. It's the other person, the loved one, family member, friend that is noticing that this person just doesn't have the motivation or the enthusiasm to do the things that made life special and exciting for them. And it's of course really challenging to see. And especially for shared activities where, let's say, a couple has been doing something and the person is still capable of doing it from a motoric standpoint, but just doesn't seem to want to do it and kind of has to be cajoled or pushed or doesn't interact when friends come around. So there are a lot of reasons for apathy or loss of motivation. One of the big things is it's just harder. So if you have, let's say, PSP, and it's harder to find the words, form the words, harder to keep up with the conversations, what might just be, relaxed and friendly banter with neighbors all of a sudden becomes very effortful. And so it's just a lot. It's a lot harder. Or if it's about going out to dinner or getting together with friends, it's a lot harder just to get dressed and get out the door and do all those little things that we take for granted. And so when a person has an opportunity to do something like this, even with all the time, they kind of in their minds think, okay, how much effort will it be versus how much will I enjoy it? And oftentimes, the truth is that people will enjoy things more than they expect, but they
Mhm.
tend to have the expectation that the work is going to be more and the benefit is going to be less. And in the end, that leads to them not doing as much. And so, one of the things that I'll recommend for Parkinson's as well as the atypical Parkinson's is for people to actually make some ratings. And this sounds a little silly, but it's kind of doing science with yourself. You make a rate on a 1 to 10 scale, how much you think you're going to enjoy something and how much work you think it's going to be to do it. Then while you're doing the activity, you do the same thing. How much are you enjoying it and how much work was it? And then immediately after, you make those same ratings. And what a lot of people find is that they vastly overestimate the amount of work and underestimate the amount of enjoyment
Mm.
compared to what they actually enjoy during and after and how much work they feel like it was during and after. And with this information in mind, people tend, you accumulate enough of these little ratings, and what that will tell a person is, you know what, I'm not a good predictor of
Mm.
how much I'm going to enjoy something. I make these reward prediction errors, as we call them. And then you stop kind of trying. People can often stop themselves from trying to talk themselves out of things because they've already kind of proven to themselves in writing that they actually do like it more than they ever expect. It doesn't
Yeah.
always work perfectly, but for people who do this, it really is helpful. And a lot of times you're going to need spouse, child, someone to help um, push them along with it. And I just saw a comment in the chat come up. I'm not apathetic, just
Mhm.
chronically exhausted from MSA. Yeah, that is reality. And that's why I mentioned, there are reasons. Life is really harder. It does take more work. We just really, I mean, we always encourage people to do really everything they can to improve quality of life and to preserve those activities that are meaningful, and to find clever ways of making it easier to do them.
Yeah.
So if there's a lot of fatigue, just make it a shorter time. Don't go as far to do it. Make some adaptations. Turns out, though, the little creative problem solving, a lot of the hurdles can be eliminated or at least reduced.
Yeah. And first understanding, what's the cause of that. And that's where you come in, because there is so much overlap or intersection between, apathy, depression, and anxiety. It's hard to tease those apart. Cognitive changes, especially around like organization and, what you mentioned there. And so to have someone to look at that whole picture and tease out, okay, what's going on with this? What's going on with this? What's going on with this? And therefore, how to address each of those individually. Or maybe someone's, a lot of times with apathy, well, if people tell us we think that they must be depressed, and then they actually find out, and apathy can be part of depression, but apathy in these diseases are actually different from depression. And so it can help to be enlightened on that in order to figure out the best course of treatment. Can you speak more to maybe the intersections with mood? Like, is that something that in neuropsych assessments you're also looking at, of like, does someone have depression and anxiety, and how does that influence cognitive functioning?
Oh, for sure. So, just kind of from a simple standpoint, if someone comes in and they're reporting that they're making more mistakes, and they're not feeling confident in whatever it is that they're doing, and they're having to go back and double check on things to make sure there isn't an error. Well, that could be it could be due to cognitive change, but also that's the kind of stuff that does come up with depression and anxiety. So when people are really depressed, they tend to notice all their mistakes. They catastrophize them. So, a little mistake is like, oh my gosh, I ruined the whole night because I was 5 minutes late or whatever. Um, and they discount all the stuff that they do correctly. And so if there's a chronic condition where cognitive changes can come up, like in any of these atypical Parkinsonisms or Parkinson's disease, they're for sure going to be focused in on that. With anxiety, people tend to, instead of just having their minds on the task in front of them, they're worried about something that might go wrong. They're worried about stuff that they haven't done correctly. Their mind is everywhere, but focused on the task at hand. So they may very well make more mistakes. And when they're feeling overwhelmed, they may not be able to just kind of talk themselves through it, to just say, okay, settle down, one thing at a time, use these sort of problem solving skills that we've developed over the years. And so the nice thing about testing is that in a controlled environment where it's just me and the person, we can get rid of some of those extra factors, and we can see what can a person do on testing in a brief period of time on a focused task. And we can see, someone who has just depression or anxiety, their testing is going to look normal. They might have a little performance anxiety, but it's not going to look impaired. On the other hand, if there is a cognitive condition underlying that, the tests will pick up on it. And that helps us know, how to treat the cognitive or issue, or in some cases, the anxiety issue. One of the things that we've been doing much more recently is treating certain variants of anxiety with medications for cognition. So sometimes using the medications that we would typically give for mild cognitive impairment or even dementia can help people think more clearly and feel a little more confident in their decisions. And then they end up, it's sort of a backdoor approach to addressing anxiety. So yeah, we're always asking questions about mood and anxiety symptoms, and I use formal scales as well. Sometimes people have really good language and they're really able to describe what their mood and anxiety symptoms are, and sometimes not at all. So for men, for example, I ask them if they're anxious. No, no, no. But then I'll hear that they're very irritable and agitated and frustrated. And then when I give the scales, I'll endorse all the symptoms, say of depression or anxiety. But if you ask, are you depressed? No, depression, that's not me.
Yeah, so it's also a matter of how people understand their own mood and describe it too.
Absolutely. How much insight they have there.
Yeah. Another complicated one. But that's the biz that you're in. It's all complicated. We had received a question during registration. Someone said, I had sleep issues for many years before my MSA diagnosis. And I know that this is very common with PSP and CBD as well. Can quality of sleep cause or worsen cognitive deficits? And how can this be assessed and addressed, and by who?
Yeah, great question. The answer, of course, is yes, for sure. Anyone who has ever had a kid knows that, you're basically sleepwalking through those first 4 months as they're up and not sleeping through the night, or and all that. That's the kind of this chronic sleep deprivation thing that happens. So you deprive a healthy young person of sleep, and they're going to struggle cognitively. So that is definitely going to impact things. So how do we assess that? A lot of times with conditions like this, we're going to want to get a sleep study done. For years, the gold standard was to go into a sleep lab to do it. But oftentimes we find that we send people there, and some of the equipment that they have isn't really needed to address the question, and then people can't sleep. So it's just the end result is, right. And that stinks, right? Because not only have they not learned anything, the person's had a horrible night just sleeping in a clinic somewhere. So now we do a lot more of these at-home sleep studies, which can be really useful. That's a great first stop. If there's untreated sleep apnea, for sure, that is going to impact cognition. And it's going to accelerate any of these neurodegenerative conditions. It's chronic hypoxemia. So basically, every time someone falls asleep, they deprive their brain of oxygen. And so that's just really adding a lot of wear and tear. So using CPAP is actually great. We see improvements not just on cognitive tests like I administer, but also on the brain MRIs. They're different. The white matter changes go away, which is really pretty cool. So if there are sleep issues going on, it's really great to have that sleep study done. And then sometimes we'll get a sleep medicine specialist involved to make sure that a person isn't using the worst thing really actually is over-the-counter sleep aids, because those antihistamine effects really, really impact cognition, and they can last into the day, and you don't get quality of sleep. And so there are actually some pretty cool new medications out there besides just Ambien and these other medications that can make falls worse, like clonazepam, that actually help people get a better quality of sleep and in some cases function better the next day. There's a few new classes of meds out there which are really exciting.
Yep.
But you need to see a sleep medicine specialist to know. Probably that's more than what most neurologists will feel great working with.
Right. Yep. I do want to note really quick, everyone, that so it's 2:57 Eastern time. And I know we're supposed to stop around now. I have a lot of questions, and I had a few more that I'd like to get to. So we might go over by like 5, 10 minutes. If anyone needs to jump off, do what you got to do. I won't take us past that, but there's so much that we can cover here. I do want to jump back to mood for a second because somebody asked a really good question in our comments. Can you speak to more on signs that we should look for depression, and maybe if medications are warranted for depression or might need to be increased for that?
Yeah, absolutely. So, um, the signs that a person themselves would look for. So these are kind of more symptoms. Symptoms are things people experience. Signs are things other people would notice. So the symptoms that a person would experience would be feeling down, feeling low mood seems to be a more palatable term, especially for men, rather than depressed. But feeling sad, feelings of hopelessness, feeling helpless, having a lot of your thoughts focused on the limitations and feelings of being worthless, or especially guilt. These are feelings that, I mean, we all have sometimes, but when that's a big part of your existence, that's sounding a lot like depression, and something that is going to be impacting quality of life, not just for you, but everyone around you. The signs that others will tend to see would be things that kind of look like apathy, not having as much interest, not having the same kind of passions for things. Um, Also, not seeing any changes in mood when a person is doing something happy, which can be tricky because with Parkinson's and the atypical, sometimes the facial expressions don't change as much. So you really need to ask. You need to ask someone how they're feeling when something happy is happening. And don't be afraid to ask. If someone says, "I'm feeling great," no, this is really exciting, and they have an expression, I'm trying to look blank. That's important to know, because you don't want to misread that, and that is something that happens, I think, kind of frequently. Um, I think when you kind of see a person really sort of looking dejected, when you hear a person constantly making negative self comments, that's a good indicator that someone with a Parkinsonism is feeling depressed. And then it's good to start asking questions about those symptoms that I would ask, of feelings, constantly feeling down, hopeless, helpless. And of course, thoughts of suicide, which can come up. It's an important one. It's real. Many people, Parkinson's or no, do have thoughts sometimes related to suicide, and it's something that is important to consider. We always have to really focus on safety.
Yep. Thank you. So let's see, looking at questions. We have a number of people, and I know, again, another complex one. I think we only have time to get to like maybe 2 or 3 more questions. I'll try to lump them together, but we've had a few people in our comments ask for a little bit more information on how you kind of help inform the diagnosis between PSP, CBD, FTD, and also a couple of people brought up posterior cortical atrophy.
Hmm.
Because, as you know, as many people with these diagnoses know, not as much MSA with those, but, sometimes the diagnosis can kind of change throughout, across those as more symptoms kind of come to light over a few months or years.
Yeah, well, I mean, it is really hard. So neuropsychological testing is one piece of the puzzle. The other things that we'll look at are neuroimaging. So we'll want to sometimes do a DAT scan. So all the atypical Parkinsonisms often have an abnormal DAT scan. So dopamine is not. Go ahead.
Sorry, I just want to clarify specifically get as much detail as you want to, but specifically with the cognitive differences. And
Sure. Okay. So briefly, there are neuroimaging differences that we can look at that can tease apart things like posterior cortical atrophy from corticobasal or degeneration. We expect to see things different there. In terms of cognitive functions, there is a lot of overlap, as you could see on those slides, a lot of things that are shared. But we'll typically see things that are at least qualitatively different. So, for instance, scores on a test of motor sequencing may be impaired for both PSP and corticobasal syndrome, but they'll be noticeably worse on one side for corticobasal syndrome and more mild on the other side, or sometimes even normal. Sometimes we'll do, in that particular example, we'll do fingertip writing. We'll trace out the letters on people's fingertips. And what we'll see for someone with corticobasal syndrome is they'll have deficits on one side and the other side will be mostly normal. And PSP, both sides should be normal. There's a number of other things that we will tend to look at. For example, with frontotemporal dementia, we'll do more things on disinhibition and impulse control. We'll see that those tend to be a little bit more impaired, whereas in PSP, they may be impaired, but there'll be more of a motor aspect to it. So one of the tests that we do that's pretty simple and actually pretty sensitive and specific is to clap 3 times. So 1, 2, 3. And so the people with the PSP will tend to have some extra claps and sometimes be surprised that they can't seem to put the brakes on that. So I don't know if that exactly gets to the question. I mean, what you said is really true. I'd love to, every time I walk out of a clinic with someone with an atypical Parkinsonism, to feel confident that I've got the right diagnostic impression. That's it's not always the case that what I do is going to necessarily be informative that day, and I'm quite comfortable saying I don't know, and passing that along. But we will ideally be able to provide at least some insights on functioning, some insights as to, okay, now that we know this, let's make some improvements from here.
Yeah.
And that baseline can oftentimes be really helpful for tracking changes over time, because these different conditions progress in different ways. So maybe, really early on, we might not know, but as things kind of progress over the years, these comparisons can really be informative.
Right. And also what I'm hearing in that is that ultimately it's a matter of individualizing this to the person sitting in front of you. I mean, it's the brain, this is the understatement of the year, is incredibly complicated. And so, getting the right diagnosis is very important, but sometimes, unfortunately, because there is not like a hard and fast diagnosis yet with these diseases, that can change over time. But neuropsychological evaluation is just one tool in that toolbox to better understand what's going on and how you manage that care. But ultimately, if you have 10 people in front of you, all with PSP, all 2 years in the diagnosis, there's going to be overlap, but they're all still going to be very different, how they present and how they progress and their experiences. So it's so easy, I think, to compare yourself to other people and other diagnoses, but ultimately it's about, your lived experience and you're just one person who can help somebody really hone in on that.
100%. There's a saying that I've heard a lot in the Parkinson's disease world that applies equally true for PSP, corticobasal, or MSA. And it's, if you've seen one person with PSP, whatever, you've seen one person with PSP. The other people are going to be different, and it's going to look different. There are commonalities, there are shared symptoms that allow us to make a diagnosis, but the way that manifests in a given person is certainly going to be unique, really just kind of depending on who that person is and what biology and environment and everything else they bring with them.
Yep. Okay. I'm going to ask you 2 more questions, and then we're going to close out. One is just a very practical kind of question, and it also speaks to like how someone gets connected with a neuropsychologist and who refers to you. But is Is this something that is able to be offered via telemedicine? Now that we're in the age of telemedicine, since a lot of people with these diagnoses do have a little bit more difficulty traveling,
So
or it
I mean,
depends on the practice.
it's a qualified yes, in that if it's a really complicated case and the referring movement disorder specialist isn't sure, I want them to come see me so I can do all kinds of stuff, whether it's, have them point to things on a board or do that fingertip writing or whatever else. I don't want to be limited and then have to punt and say, I don't know, because I wasn't able to do the right kinds of tests. If we're talking about just looking to see, all right, how is a person's memory, or, what are some of the verbal skills like? Then yes, by all means, it's great to be able to do stuff by telemed. I'm a huge proponent of telemedicine for that purpose, but it doesn't always work
Right.
for complicated situations. But a qualified yes.
Yeah. Yeah, it's very case by case, depending on what they are, what their goals are, what you need to assess. And it's, that's sort of similar to if someone's doing their neurology appointment, telemedicine, or they need to come in and actually, have someone put their hands on them and watch them walk down the hall and everything, or, any of these therapies. Okay, one more question. And this speaks to the care partner's perspective on this. Someone had shared, it breaks my heart to see my wife struggle with her memory, thinking, and ability to express her thoughts. She can be pretty impulsive and is a little confused at times. It's such a big change from who she was before. How can a care partner be supported through the cognitive decline of their loved one? And also, I think that question goes for the person with the diagnosis, seeing the changes in themselves as well.
Yeah, for sure. I mean, it's not a fun thing. We always talk about, what kinds of things can we do to make life easier. We talk about how can we bring more support in for the care partner. How can we get them some time away, some time for themselves, for self-care, and all these are important conversations. But there's really no hiding it that it is a very sad tragedy. It's really a grief process of going through that and losing someone that you love, and seeing that person no longer there in the way that you remembered them being, and the way that it was. And I think approaching it kind of from a grief standpoint can be helpful, because that's moving toward acceptance.
Yeah.
And moving towards acceptance, I think is really kind of always good, because it puts a person in the best position to still take what's good in that relationship and in that person. Um, and to be able to cherish it. But really, I think that the importance of getting support, getting, not just support groups, but from friends and family, wherever they can be found, is really key. And I think being assertive and asking for help is
Yeah.
also really an important thing. It can be a tough thing, kind of suck up the pride and ask for that help, but it's important.
Yep. All also true of reaching out and building that support system. And I really like what you said about naming it as grief. I think that validates that experience and it normalizes it. And, holding the space for that and also the good things at the
Yeah.
same time.
And
What
grief is,
Go
and
ahead.
grief is a process, right? We don't expect someone to jump to acceptance. That's just not how it works. There are stages there that one goes through that are rough and challenging, but that is the process. And it's okay to be in that process.
Right. Yep. It's something that we can definitely connect or relate to across humanity, and so I appreciate you sharing that. I know I took us over, so I'll start to close us out, I do want to mention really quick, everyone, that Dr. Turner kind of touched on some treatments and management of cognition. We didn't really get into the medications around that as much today. We were more focused on like what are the symptoms and how do you assess those and kind of tease it apart. But maybe for a future, or not maybe, I'll plan for a future webinar, hopefully this upcoming year, to bring somebody else on to delve into that a little bit more deeply around how do you manage them and treat them more from maybe a medication standpoint as well. Dr. Turner, thank you so much for taking the time to share your expertise on assessing cognitive changes and answering questions from our community. Thank you to everybody who is watching or will be watching this later, for everyone who interacted and submitted questions to this program. Again, today's webinar will be archived for later viewing. I know we covered a lot today. It's also okay to watch this in small digestible chunks and to revisit the content and share it with other people who may be interested in this content. If we were not able to get to your question today, and I know we had a lot of questions, so that may have been the case, but we encourage you to email us at info@curepsp.org, and we'll do our best to get you an answer or to connect you with the right resource from there. I do have a couple of very quick announcements before I let you all go. Our in-person fall family conference was in November in Philadelphia in partnership with the CurePSP Center of Care at the University of Pennsylvania. We were able to record those presentations, and we are showing them, as well as including a live question and answer session and live mix and mingles during our 2-part virtual family conference. This webinar today is actually the cheese and the bread sandwich. You know what I mean? I'm hungry. Between those 2 parts right now, part 1 was this past Friday, and part 2 is actually coming up this upcoming Friday. And it's not too late to sign up for that yet. But even if you can't attend those, all of those recordings will also be available on our YouTube channel in the coming weeks. Our next webinar will be a community conversations webinar, and that will be on Thursday, February 2nd. That's a little different from Ask the Expert. It's where I have a conversation with a different kind of expert, which is someone in our community of PSP, CBD, and MSA who has personal experience living with one of these diagnoses. And for that one in February, we'll be joined by 2 of our peer supporters who actually facilitate our brand new support group for grandchildren and young adult children of people with PSP, CBD, and MSA. And they'll be telling us about their relationships with their grandparents and their roles in their care, which is frankly just a perspective we don't get to hear from our community of care partners very often. So I look forward to that. I imagine it'll be a very powerful conversation. So please save the date and stay tuned for more information on that. You will be able to find information for all of our upcoming events by scrolling down to the calendar on the homepage of our website, curepsp.org. Lastly, I always do like to mention how we're able to offer these webinars as well as all of our resources, including our printed educational materials, our large support group programs, and much, much more because of generous donations. We're actually 100% funded by people living with one of the diagnoses that we serve and those who are caring for and about them. So thank you for your support of CurePSP's mission to raise awareness, build community, improve care, and find a cure for PSP, CBD, and MSA. Dr. Turner, thank you again. Thanks everyone for going over a little bit and attending this today. I wish all of you, everyone viewing, and Dr. Turner a happy and healthy holiday season and new year. Take care, everyone.
Likewise. Thank you.